Thank you all for being until we are past 5 now. Thank you all. So this is a satellite symposium sponsored by Amgen, and I've been asked to talk about the role of Blinatumomab in the consolidation therapy of Ph-negative acute lymphoblastic leukemia. So BALL, acute lymphoblastic leukemia, we still have unmet needs in acute lymphoblastic leukemia. So although 90%, more than 90% of patients will achieve CR with induction chemotherapy, still around 30 to 50% of patients will have an MRD positive disease, and these patients will eventually relapse. And relapsed patients with BLL usually have inferior outcomes, although the outcomes in the recent years has improved with the use of immunotherapy and cellular therapy. So usually we treat ALL with induction followed by consolidation and maintenance, and this is usually based on multi-agent chemotherapy, and therapy usually lasts for 2 to 3 years. So looking at the outcomes of hyper-CVAD, which is a common adult regimen used in our country in many centers. So when they looked at the outcomes at 5 years, the 5-year survival for younger patients less than 40 were 51%. So around half of the patients were dead by 5 years. And in patients who are more than 40 up to 60, the outcomes at 5 years were 30%, and for patients who were above 60, the 5-year overall survival was less than 20%. This is in the MD Anderson data. So one way to improve the outcomes in ALL patients is to use a pediatric or a pediatric-inspired regimen. And the French group were among the first to report more than 20 years ago that using a pediatric regimen will improve the outcomes in the long term, showing a survival of 78% for a pediatric protocol versus 45% for the adult protocol. Stock and colleagues also showed that using a CCG regimen in a matched cohort as compared to the CLGB resulted in an improved survival at 7 years, 67% versus 46%. Meta-analysis of multiple clinical trials showed that using a pediatric-inspired regimen were superior to conventional adult chemotherapy regimen in adolescents and young adults with ALL. And the outcomes were mainly derived by the lower relapse. So these protocols lead to lower relapse because the non-relapse mortality were comparable between both types of therapy. So the CLGB 10403 was actually implementing a pediatric inspired regimen in treatment of adolescents and young adults with ALL. Median age was 24 years, 25% of patients were 30 to 39 years of age. And they use 4-drug induction followed by consolidation, interim maintenance with cabezi-methotrexate, delayed intensification and maintenance. And they have shown that at 3 years, the overall survival was 72%, event-free survival was almost 60%, and the outcomes were lower in patients with BH-like signature and lower in patients who were MRD positive. When they compared the outcome of the 10403 to a matched cohort from the EBMT, using chemotherapy actually was associated with better outcome than transplanting patient in CR1. I think Dr. Hind is here in the audience. So together with our colleagues in National Guard Riyadh and Dammam, we reported the comparison of pediatric-inspired regimen which was BFM versus hyper-CVAD. And we have shown that the outcomes are better when using a pediatric protocol versus adult protocol, which was hyper-CVAD, in terms of overall survival and disease-free survival. So what are the main differences of the pediatric SPAD regimen versus the adult regimen? So the pediatric regimen have more non-myelosuppressive chemos, mainly the steroid, vincristine, and the asparaginase. And we use less antimetabolites, less anthracyclines. The ITs are more intense in the pediatric and pediatric SPAD regimens, and the decision for transplant is based on the MRD responses rather than the baseline risk stratification. So how can we improve further on the chemotherapy outcome for adult Ph-negative ALL? So an important way is to use the immunotherapy, like rituximab and ofatumumab, anti-CD20 antibodies, the use of inotuzumab, which is a conjugated antibody-drug conjugate against CD22, and the use of Blinatumomab, which is a bispecific T-cell engager against CD19. So the MD Anderson group were first to report the improved outcome with the use of rituximab and pre-BLL, and this paper published in JCO 15 years ago. They showed that the use of rituximab improved the disease CR duration and the survival in patients with CD20 positive pre-BLL. The French group subsequently did a randomized clinical trial in CD20 positive pre-BLL. They showed the improvement in the event-free survival, 55% at 4 years, versus 43% in patients without rituximab. And what rituximab did was actually, in that trial, there was significant reduction in the cumulative incidence of relapse. So with rituximab, the cumulative incidence of relapse was 25% versus 41% in the control arm. Inotuzumab was mainly tested in older patients with ALL, and in this trial by the MD Anderson group, they compared the INO with mini hyper CVD in this phase 2 trial published in Lancet. So they had initially 52 patients, median age was 68, and they were able to show an overall survival of 56% in those quite older population. So when they amended the protocol, they did fractionation of the inotuzumab. So the total INO dose was 2.7, was fractionated over 4 cycles, cycle 1.9 milligram per meter square, followed by 0.6 milligram per meter square in cycle 2 to 4. And they added blinatumomab consolidation, 4 cycles. And then after that, they added blinatumomab even to the maintenance phase between the bump. So total of 8 cycles of blinatumomab. And in their most recent update, they showed that the overall survival of the whole cohort at 5 years was 47% for a median age of 68. If you remember, the outcomes with hyper CVAD were less than 20%. And if you look to the Kaplan-Meier curves down right, you can see that patients who are less than 70 years of age with non-poor risk cytogenetic had the best outcome with a 5-year survival exceeding 60%. So a recent important landmark trial in the field of BLL is the E1910, which tested the use of blinatumomab for MRD-negative acute lymphoblastic leukemia. So blinatumomab is a bispecific T-cell engager that binds CD19 and CD3, and so it brings the CD3 positive T cells to the CD19 cells, leading to cell activation of the T cell and target cell lysis of the CD19 cells. So the blinatumomab in this trial, the E1910, was a global randomized controlled phase 3 trial of blinatumomab alternating with chemotherapy in the frontline consolidation of adult with Ph-negative ALL. And they had initially 488 patients, And when they reached the randomization of the MRD negative, 224 patients were randomized. So the inclusion criteria were adult, age 30 to 70, and they were treated with BFM-like induction, consolidation modeled after the MRC UCAL 12 ECOG 2993. Big asparaginase was given for patients less than 55 years of age, and rituximab was added for patients who were CD20 positive. So this is the study schema. So they give induction, 2 cycles of induction. It's actually induction consolidation, followed by intensification. And after intensification, MRD was assessed. For patients who are MRD negative were randomized, and patients who were MRD positive actually received blinatumomab without randomization. So this is the protocol. If you look at the induction cycle, 128 days, it's actually a 4-drug induction similar to the pediatric regimens with daunorubicin, vincristine weekly, dexamethasone 1 week on, 1 week off, and asparaginase. And the cycle 2 induction is actually a consolidation cycle. You usually call it consolidation because it has cyclophosphamide, cytarabine, 6-MB, and asparaginase and intrathecal methotrexate. This was followed by intensification with methotrexate, high dose, 3 grams per meter square, and then the randomization. So concentrating on patients who are MRD negative, they were randomized to receive either blina with chemotherapy or chemotherapy alone. And they had 112 patients in each arm. Median age was 51-50, and actually around almost 60% of patients were less than 55 years of age. Male to female were equal distribution, and they did the combined risk stratification based on the molecular profile, and they divide the patient to favorable, intermediate, and unfavorable. Almost 40% of patients in each arm had unfavorable molecular subtype. So what was the rate of stem cell transplant in that trial? So 20% in the blinatumomab arm received on-protocol transplant, 5% off-protocol transplant, and in the chemo arm, 20% again received on-protocol transplant and 9% off-protocol transplant. So equal between both arms of transplant. This is the primary outcome of the trial, which was the overall survival, superiority of blinatumomab versus chemotherapy. You look at the 3-year overall survival, 85% with the use of blinatumomab versus 68% with the use of chemotherapy. There were 17 deaths in the blinatumomab group, 8 from relapse and 9 from non-relapse mortality, and 40 deaths in the chemotherapy arm, 31 from relapse and 7 from non-relapse mortality. So mainly the deaths were driven by the relapse in the chemotherapy arm. So if you look at the relapse-free survival for the same cohort, superiority of the blinatumomab versus the chemotherapy hazard ratio 0.53, so almost 50% relative risk reduction of relapse. This is an interesting Kaplan-Meier curve. So if you look at the concentrating on patients who were less than 55 years of age, so the improvement in the outcome here is very striking. The hazard ratio is 0.16, so more than 80% relative risk reduction of death with the use of blinatumomab in patients who were less than 55 years of age. So looking at the outcomes according to the molecular profile, so what they did, how they defined the molecular profile, patients with favorable molecular profile were patients mainly with DUX4 rearranged, 119 or BAX5 altered. Patients with unfavorable profile, including patients with what we call the MLL or KMT2 rearranged ALL, PH-like ALL, and patients with KMT2 rearranged and PH-like ALL mainly. So those were the unfavorable combined molecular risk. So if you look at the outcomes in both patients with favorable and unfavorable, superiority of blinatumomab versus chemotherapy alone. So looking at the forest plot for subgroup analysis, here you can see clearly that younger patients, less than 55 years of age, had the best outcome with the use of blinatumomab in the upfront consolidation. Looking now to the adverse event, the adverse events were comparable. However, there were more neurological and psychiatric adverse events with blinatumomab, 23%, grade 3 to 5, and this included actually side effects like headache, versus 5% in the chemotherapy arm. And during blinatumomab cycle 1 to 2, CRS was observed grade 3 in 3% of patients and grade 4 in only 1% of patients. So in the ASH 2023, they had a poster presentation about the outcomes according to the number of cycles from the E1910 trial. And they showed that in that abstract, that patient who got 1 to 2 cycles of blinatumomab had a trend toward a better outcome. However, that did not reach statistical significance. So the p-value here was 0.22. And also in the same abstract, they report that the best outcome were in patients who got 4 cycles as compared to 1 to 2 cycles. So in summary, I would like to say that the E1910 shows significant improvement in overall survival among patients 30 to 70 years of age who had an MRD negative remission of B-cell ALL and received blinatumomab plus chemotherapy in the consolidation as compared to chemotherapy alone. And currently, if you check the NCCN guidelines for both adolescents and young adult patients and adults less than 65 years of age without substantial comorbidities, the preferred regimen for consolidation is the E1910 regimen. And this is my last slide. Thank you very much.